Thank you very much for being here and for having given me the opportunity to present the work we are doing in Israel and the special kind of focus that we have. And thank you very much for the invitation. Now, I will be talking not about survivors as such, but about children at the threshold of the survivorship phase. Now, and another special thing is that I will be talking about a new study and new findings that have not yet been published. So children with hemato-oncological diseases suffer from physical and psychological pain and other difficulties, and we all know about it, and we have heard about it today. Very, very interesting and updated reports. Many studies show that the quality of life of pediatric cancer patients is negatively impacted. So not only we know that and we expect it, but we have also shown it. And there are many studies that have shown it in different phases. Now, quality of life is a very, very important component of the whole situation, and it's very difficult to see here because I have a very, very light, the contrast is very light. I can barely read this, but okay. So anyway, quality of life is an important component of the whole situation, and maintaining it, maybe we can get a better, no, not back, but a little bit better contrast. I can barely see the letters here, but okay, I'll guess what it is. So quality of life, as I said, we all know, is a very, very important component of the situation, and is really, and has become actually a co-target of the treatment of cancer in general and pediatric cancer specifically. So we treat medically and we treat the whole person, and the whole person is always with a focus on quality of life. Now, most of the studies on quality of life of pediatric cancer patients do not consider changes in time. That is, it's always a picture of a certain phase. It's very difficult to follow longitudinally, I know. I certainly know because we've tried to do it. And the use of quality of life measures dealing mostly with distress and health, because this is the nature of many of the quality of life measures. And most of these studies do not consider the different perspectives of children, that is parents, children of course, and parents' view of children, which is a very, very important aspect of the situation, because this really reflects how much the parents can really help their children. That is how the parents view the children's quality of life. Okay, now, the major questions of the study I'm going to report to you is, how does the quality of life of pediatric cancer patients change from the first stage of diagnosis, that is from the first month after diagnosis, to the end of treatment after 1 year? Mostly, the major part of the treatment is ended after 1 year. And then the next question was, what are the differences between the changes in different domains of quality of life, not just the overall estimate of quality of life, but the different domains, which I will present very soon. And then what are the differences between children with different diagnoses? It's not exactly the same having leukemia or lymphoma or a solid tumor or a brain tumor, very different. And then what are the differences between the views of children, of parents, and of parents about children? And all these questions are of crucial importance if we are to provide targeted, individual, and efficient treatment to the children. So the purpose of the study that I'm going to report to you briefly was to examine the quality of life of pediatric cancer patients at 2 points in time, children with different diagnoses, and from 3 perspectives of the children, of the parents, and of the parents about children, using this very same instrument so that we can compare, and in general, and then in the and not only the quality of life in general, but also in 15 different life domains. So the participants were, at this stage, 35 children, 3 diagnoses, leukemia, lymphoma, solid tumors, and brain tumors, age 8 to 18, parents, there were 39, parents of these same children, right? And the design was a repeated measures, 1 month after diagnosis and then 12 months. The same questionnaire was administered separately and individually to the 3 samples, the children, the parents about themselves, and the parents about their children. And the tool was a very, very reliable and highly valid tool, which we call the Children's Multidimensional Quality of Life Inventory. And we use 2 types of statistics, the mixed model, the hierarchical linear, and the GLM, the generalized linear model for comparisons. Okay, the basic idea about quality of life is that it is a subjective view that the person, that the individual, including the child, has of himself or herself. It's phenomenological. We don't ask, how did the cancer or the treatment impact your social life, but how is your social life? Because no one knows exactly how it impacted, which is an item that we find in many of the measures that we do not use here. It's evaluative. Okay, it's multidimensional, that is not only in general but also specifically, and we are very well aware of it, that it changes, and it should be a tool that enables changes. Okay, the children's quality of life was validated up to now in more than 10,000 children, which is a lot for a tiny country like Israel. So actually most of the children already had it in some form. And it exists in 5 languages, 5. This is how it looks. You say, I sleep well, and the child either notes or draws or paints and says, mostly, sometimes, rarely. I'm sad, sometimes, mostly, rarely. They can point, they can draw, etc. And it's administered either being read by oneself or being read to them. And the responses are checking, coloring, pointing out, never mind. So the important point here is that the instrument yields scores on 15 scales, functioning, which we found by a lot of focused interviewing with children of different types and in different countries, functioning at school, social functioning, cognitive functioning, functioning in the family, physical state, worries, basic needs. And for children, for example, having a friend is basic needs, it's not social functioning. Then the body image, sense of mastery and independence, self-esteem, negative feelings, positive feelings, stress, fun, which is very important in children even more than in the quality of life measures of adults, and of course motivation to go on, to do things. So this is how it looks, and this is how it looks statistically, that all these measures really are, all these scales are really manifestations of quality of life and related to it very strongly. Okay, now for the results. This is just to show you that there are differences that are differences in quality of life, and this is the general score, right? That go with age and diagnosis and who is the interviewed one, the child, the parent, or the parent about the child. That is how the parent thinks that the child is. Okay, and this
2 minutes.
We have
2 more minutes.
I'm sorry because I've been sitting here. I will do it in 2 minutes,
Please,
but I've been sitting here in presentations that certainly overran the time. But I will go with you as you say. But I don't think it's right. So now these are the results, quality of life responses of children, stage 1. I will summarize it later in this form. Okay, and this is about the parents, and this is about, okay, the summary. There is very good matching between children and parents on children. All 8 domains with changes in the children's sample are also included in the 10 domains with changes in the parents' on children's sample. So that's a very good news, and it's unlike many other studies where sometimes we find that parents do not have a very accurate view of the children's view. Maybe, okay, now the parents about themselves, there are 9 domains, but only in 5 domains they are equal to those of the children. That means that the quality of life of parents and of children is, of course, different. Then, domains showing improvement in all groups, and that's important. The total score, functioning at school, physical state, which is at least shows that we are on the right track and it's a valid instrument, fun, mastery, and independence. Domains without improvement in all groups, worries, that is, after 1 year, they still have a lot of worries, just as in the beginning, although the content of the worries may change. Cognitive functioning, social functioning, self-esteem is even a decline, basic needs, and then the positive feelings do not improve. Then, again, what we have here is that in regard to, so here we show that the main, most of the positive changes we had in regard to leukemia and lymphoma, we had a few changes in regard to brain tumors, but mostly declines. So the key characteristics of quality of life are specificity in regard to phase of treatment and disease, diagnostic group, and domain of quality of life. The implications are that quality of life in pediatric cancer patients needs to be assessed repeatedly, not just once. Just as you need to have the physician looking at you every 3 months or so in different phases, so the same thing goes for the health psychologist or psycho-oncologist that should be in charge. Special attention needs to be paid to specific domains of quality of life, and that's very important to have this chart showing what is the situation of that child in a specific period. Special attention needs to be paid to particular diagnostic groups. Brain tumors are different from other solid tumors. And special support needs to be provided to children with, as I said, brain tumors. Thank you very much.
Thank you very much, Dr. Kreitler. Thank you. Thank you so much. Thank you very much for the comprehensive study on the quality of life of the patients of hematology disease.